Next up, we have Dr.priya Nair. She is a proud alumnus of AMRITA Institute of Medical Sciences, having completed a DM in Gastroenterology and Fellowship in Therapy and Endoscopy from AMRITA Institute of Medical Sciences. She is a skilled clinician and has published several research publications in both national and international journals. She is currently working as an associate professor in the Department of Gastroenterology in AMRITA Institute of Medical Sciences. Over to you, ma'am.
Good evening, everyone. At the outset, I would like to express my gratitude to all the organizers of this AMRITA Medicine update. It's an honor to be able to take part in an internal medicine CME online, and especially amidst this time of COVID, these kind of CMEs go a long way in keeping us all up to date, as well as help us to feel connected amidst this time of external chaos. So I had been asked to discuss the topic of fever or pyrexia of unknown origin and the role of endoscopic ultrasound. So I'll get into the topic right away. So I'd like to start with a case that I had actually worked up when I was doing my therapeutic endoscopy or EUS fellowship. There was a 20-year-old boy that had come. He had had around 8 to 9 months of fever, a daily evening rise. Highest was about 100 to 105 degrees Fahrenheit. And he didn't really have any other symptoms. He had been admitted multiple times just for a battery of tests. And all tests, he'd even done a bone marrow biopsy because his father had passed away of leukemia. So his family was quite worried about these daily fevers. So they had even done a bone marrow biopsy, but everything was normal. So finally, when the fever started to become a little bit more frequent, he had few spikes in a day. He was brought here. At initial examination, there was really nothing. His physical examination was unremarkable, no lymph nodes, nothing. All his routine labs were done, and they were all normal, except that his C-reactive protein was 18. So as part of his evaluation for fever, he had a CT abdomen as well as chest repeated here. And one of the findings that was there, actually the only abnormal finding in the CT was that there was a 2 into 1.5 centimeter isodense lesion. It was actually hardly visible on CT. The radiologists were not sure whether it was a peripancreatic lymph node or maybe even a pancreatic mass or some kind of a gastric tumor and submucosal tumor of the gastric or a duodenal wall. They were not sure exactly what it is because it was very isodense. There were no other lymph nodes noted, no other collections, masses. Otherwise, the CT chest was normal and the CT abdomen was unremarkable except for the small little lesion. So he had all his tumor markers sent, everything came as normal. And he was then referred to gastromedicine for an EUS study. So on EUS, we found that unlike the CT, which showed a very isodense lesion, on CT, there was a very well-defined hypoechoic homogeneous mass, which looked more like a lymph node than a mass that was arising from the pancreas. And we could quite easily access it because all the structures in the retroperitoneum are very easily accessed through the through endoscopic ultrasound. And we did an FNA as well as an FNB or a fine needle biopsy of the mass. And this is basically what was seen. You can see some lymphocytes, some inflammatory nucleus and neutrophil, and it is all seen scattered amidst a lot of fibrous tissue. Samples had also simultaneously been sent for TB evaluation, cultures, cell block, all kinds of testing was done on the tissue, and everything came as normal, including IHCs that were sent. And finally, the diagnosis given by the pathologist was inflammatory myofibroblastic pseudotumor of the lymph node. This is basically a very rare etiology, a very rare tumor, and it is also not very well understood. Sometimes it comes in the background of autoimmune diseases. Sometimes, more often than not, it is just a completely independent thing, and its origin or its etiology is very poorly understood. So we'll get into the topic, and then at the end we'll discuss what actually happened with the patient. But I'd like to start with just a very brief discussion of fever of unknown origin to begin with, FUO. It's actually quite silly for gastroenterologists to be discussing FUO with internists. But that being said, since there isn't any other discussion on FUO, we'll just briefly go through some of the points. So as we all know, the definition for FUO was actually written in stone as long ago as 1961, and basically the definition hasn't really changed. It was derived by Petersdorf and Beeson, and essentially there are three aspects to it. You need to have a fever higher than 38.3 degrees centigrade on several occasions. The duration of fever should be for at least 3 weeks. And there should be an uncertain diagnosis even after 1 week of study in the hospital. So these are and if you look at through the years, this really has never changed. So this particular scenario has continued to baffle physicians from the beginning of the century. When we look at various studies done on fever under evaluation, you see that the first publications on PUO was as early as the 1910, 1930, 1913. And there has been multiple studies through the decades, the largest study being more recent, which was actually done using patients from Asia, Europe, as well as the Middle East. It was the largest study published by FUO, and it had more than 3,000 patients involved in the study. And if you look at all of these different studies, essentially you'll find that the same set of conditions formed the eventual cause or the diagnosis of all of these patients with fever under evaluation. And you'll find that the etiology essentially breaks down into infections, malignancies, or systemic rheumatic diseases or autoimmune diseases, including vasculitis, rheumatoid arthritis, SLE, polyarthritis nodosa, all those set of autoimmune diseases. So between these three, infection, malignancies, and autoimmune diseases, that essentially covers a large amount of the final etiology or the final diagnosis for patients with fever of unknown origin. And if you look at, so here were the breakdowns of the causes of PUO in all those different studies, and you'll see that infections form an important part, including most important mycobacterial infections. Unlike areas like India, where we are lucky enough to have our internal medicine professors, as well as all doctors have, alarm bells ring as soon as you have a patient coming in with any fever, and tuberculosis is always very high up in the list of differentials. But unlike areas like ours, in many parts of the world, TB is considered to be a very rare disease, and hence you can see both in Asian studies as well as studies abroad, TB forms a very large number of patients that present as fever of unknown origin. Some of the other infections, including endocarditis, abdominal abscesses, and then you have all your malignancies like lymphomas, solid tumors, and other autoimmune conditions like lupus, rheumatoid arthritis, giant cell arthritis, and rheumatic fever as well. So here is just, I took the long list of differentials that were given in UpToDate. And if you look at a lot of them, you find, see, they've put in bold some of the very important causes of PUO. And you'll see that abdominal abscesses, tuberculosis, lymphoma, GI malignancies like hepatocellular carcinoma, neuroendocrine tumors, liver metastasis, sarcoidosis, a lot of these very important or more common causes of fever of unknown origin arise from the thoracic cavity as well as the abdomen. And this has always been a big challenge for physicians from reports of PUO all the way in the early 1900s. And this is essentially because the thoracic cage as well as abdomen were always considered as like secret hidden areas, in the sense that it couldn't be accessed. Even physical examination was very difficult. We have our traditional methods of palpation, percussion, but that still cannot give you a definitive cause for fever under evaluation. And even after the onset of cross-sectional imaging like CT and MR imaging, still there was a big question of how do you access the tissue? How do you get the tissue from the retroperitoneum, from the thoracic cage? And until the onset of endoscopic, either EUS or even EBUS, endobronchial, until these modalities came into vogue, even the CT guided biopsies all had their own set of limitations. See, if you look at through the history, you can see that the incidence of infections as a cause of PUO has gradually come down. Malignancies as a cause of PUO has gradually come down. And all of them essentially are showing a downward trend except for one, and that is this category of no diagnosis. And I put this slide up because I think it's very important to note that as technology increases, your infections, everything else may become easier to diagnose, but this particular entity of fever of unknown origin, that's always going to be there, because unfortunately technology will always have its limitations. And as you can see through time, the cause of fever of unknown origin has yielded no diagnosis more and more as your technology has improved. And it's not necessarily because technology is failing, but it's just that we won't ever necessarily be able to catch up with the changes in disease over time. So we briefly spoke about this, but what are the challenges? Essentially, one of the many challenges involved is tissue sampling, because considering that a significant number of the diagnosis of PUO lies in malignancy, infection, or autoimmune disease, you basically need to confirm that with tissue. So reaching the areas of difficulty, most importantly being intra-abdominal as well as mediastinum, that challenge is significantly met by EUS and EBUS. Even CT-guided FNA techniques have their limitation because you cannot cross bowel. That's the biggest problem. You cannot cross any gas-filled or air-filled areas. So going through the lungs, accessibility going through the bowel, all that becomes limited when you're doing a CT or MR guided FNA technique. So here's where you have the role of EUS. Endoscopic ultrasound, it's a simple concept. Endoscopy had been discovered as early as the 1920s. And by putting an ultrasound probe at the end of the scope, essentially you're giving it a new power or a new modality of diagnosis with the same scope. So it is one of the easiest methods to access mediastinal and retroperitoneal masses or lymph node enlargement. And the advantage, especially of EUS, is that it's a very simple outpatient procedure that now over time has become very safe. It has a very high safety profile. There are disadvantages, that being said, to EUS, though they are essentially that it is still quite an expensive test. It also needs to be done under anesthesia because it takes a good 1 hour to 1.5 hours to complete the test, this is also because it is done along with something called ROSE, or rapid on-site evaluation, which we'll discuss later on. But nobody can really sit with an endoscope in their mouth for 1.5 hours. So it has to be done under anesthesia. It need not be done under general anesthesia where the patient needs to be intubated, but there needs to be deep sedation. Also, patients that have a short neck or obstructive sleep apnea, there can be some challenges. But that being said, these are all challenges that can be very easily taken care of with some amount of tender love and care and proper training of scope usage, as well as techniques of EUS. So a few basics on EUS. Originally, when EUS had come into vogue, it was a radial transducer. That is, there was 360 degrees vision all around the actual EUS transducer. And this is essentially like a CT. So you have CT cuts or axial cuts of the chest or the abdomen, and it made it very easy for doctors to be able to compare the CT films or CT images with the EUS images. It helped to compare it on a one-to-one basis, so you could actually find things. It's interesting to note that a lot of masses that need not be or may not be visible on CT are often visible on ultrasound, even if it's just transabdominal ultrasound. But and there also are a subset of masses or collections that may not be very well seen on an ultrasound, but that are very well seen on a CT. So it does go both ways. So what the main disadvantage of this radial EUS was that there is no way to do if the transducer is 360 degrees, you cannot actually, the needle would come out of the tip of it, and you would not be able to see the passage of the needle. So it would still be a blind biopsy. Hence, radial EUS was very quickly replaced by linear EUS, where the transducer was only on one side. It was a 120 degrees, some are 145 degree of visibility or penetration of the ultrasound waves. And as you see here, there's a working channel. And through this working channel, you can introduce catheters, you can introduce needles, mainly FNA needles or fine needle aspiration or biopsy needles. And as you can see here, the needle actually passes within the line of vision. And because of that, you have real-time biopsy, and it's a much safer procedure because you can actually real-time look for vessels, vasculature, reduce the chances of bleeding while taking a biopsy. So it's targeted biopsy essentially. So here are some examples. As you can see here, both of these are radial ultrasounds because they have 360 degree vision. Here you have of the mediastinum. So you can see both of these are of the mediastinum. So you have the aorta and the spine. And here you can see multiple matted nodes. This is a case of tuberculosis. Here's another patient where you have, this is the arch of the aorta. Here you have one thing to remember, any of you who may have done ultrasound imaging, you'll know that air is a big problem. Anytime there's air, you cannot see an entire wedge of vision is lost. Everything behind the air pocket or air shadow is completely lost. So the esophagus inherently has air because the gastrointestinal tract has gas always. So one important aspect of EUS, as you might have seen here, is you need to obliterate all space for air. So there's a balloon at the end of the EUS probe. This balloon is inflated to fill the entire esophageal lumen, and that helps to prevent any air from coming between the transducer and the tissue and gives us this 360 degrees. So this esophagus that they're pointing to is actually the water within the balloon of the scope. This is the scope. And you can see here there is a mediastinal mass. Even though it is not commonly done, actually you can pass needles even through vessels as large as the aorta, although we are always afraid to do it as an endoscopist, but there isn't really any major reason why you should not reach a mass unless there's some other better way to diagnose it. So one of the most important things when it comes to EUS of the mediastinum is sampling lymph nodes. So when it comes to sampling lymph nodes in the mediastinum, we have two modalities, as I mentioned before. You have the endoscopic ultrasound and you also have the endobronchial ultrasound. So it depends on where the nodes are, and you have to choose nodes or even mass or collection or whatever it is that you need to sample. You need to decide which is the best modality based on the location. So we all know the various stations of the nodes in the mediastinum range from station 1 all the way to station 14. So here you can see that the central stations, as well as the stations just below the carina, subcarinal nodes, all of those stations are accessible by EUS. Whereas the more peripheral they go, especially into the lungs, like all this 10, 11, 12, 13, 14, as well as pulmonary masses, those have to be sampled by the EBUS alone. So this is the usual chart we study to remember when to use EUS versus EBUS. So you can see that 2, 4, 7, these can be sampled by either EBUS or EUS. Then you come to 8, 9, as well as all the intra-abdominal, hepatic, adrenal gland, all those masses or nodes, you need to use the EUS, versus all the inner groups of lymph nodes all the way from 10 to 14, those require EBUS alone. So here's some more images that show you. So unlike the other one, initially we looked at the radial scopes where you have 360 degrees visualization, but you cannot sample anything with that. That's more for diagnosis. Here you have the linear EUS, and you can see these are matted lymph nodes in the mediastinum. This is the pulmonary artery. This is the left atrium. Here again, you can see between the pulmonary artery and left atrium, you have the nodes sitting there and under visualization. So you can watch and make sure, obviously you're in a very precarious area. You cannot overshoot the needle, which is why these needles have a lot of safety precautions, a lot of locks. You set that the depth of your penetration, and also otherwise you're going to go straight into the heart. So you have to be very careful while sampling these nodes. So there are many tests that can actually be done with the FNA and FNB samples. Originally, it was only cytology, and you send these cells in for centrifuging, and it becomes a little cell block, which they look at under the microscope. So that was all that could be done initially. But that has now changed with the advancement of technology and the advancement of the needle types. Now we can check, we actually can get core biopsy pieces. You can do immunohistochemistry on them. Also, we have all the infectious panels that we can send, including cultures, mycobacterial, bacterial, as well as fungal, gene expert, AFB smears, and aspiration of cyst or aspiration of pus can all be done using these EUS-FNA or FNB needles. And the most common diagnosis that we get from these, especially in the chest, are TB, fungal infections, bacteria, and certain other bacterial infections. Obviously, Brucella and all are rarer. That being said, we have had quite a few cases of them here that we have diagnosed. Then your malignancies, including solid organ, metastasis, lymphoma, as well as neuroendocrine tumors, and inflammatory etiologies, including sarcoidosis. There's one thing to note: there are very few absolute contraindications for EUS-FNA, and one of them is actually mediastinal cysts, because mediastinal cysts usually have a high pressure within them. And no matter how small a gauge needle you use, there's two issues: rupture of the cyst as well as introducing infection into the cyst. And both of these can lead to life-threatening mediastinitis. And we all know that draining the mediastinal collections are very difficult to do. Hence, mediastinal cysts are one thing that just cannot be touched either by EUS or EBUS. There's a one of the advantages, another advantage of EUS is the concept of ROSE, or rapid on-site evaluation, which is actually the standard of care internationally. The pathologist or the cytologist actually comes for each and every procedure, and every time we remove a sample, we smear it immediately on site, and they check it under the microscope, and they have to confirm that we have adequate sample for them to make a diagnosis. And the reason why this is done is manifold. Number one is it is quite an invasive procedure, even though it is just a biopsy. You're doing it under some form of sedation. You don't want the patient to have to undergo this multiple times. So you need to make sure that at this particular sedation, you keep on taking samples until you ensure that the pathologist can give you a diagnosis. Also, there may be multiple different nodes, multiple masses, and you can also sample different masses and find out real time which mass may give the most sample, the most adequate tissue sample. Some masses or some nodes may be mostly necrotic and you cannot make a diagnosis off of them, versus other nodes that have a better solid component can actually give them more cells to read off of. So these are all the advantages of having rapid on-site evaluation, and it's essentially the gold standard internationally. So this is a sample of on-site staining, and here you can see there's an ill-formed granuloma, and this was a patient that had a tuberculosis. So going deeper now from the thoracic cage, you're actually entering into the abdomen, and the EUS is best for retroperitoneal lesions or nodes, all the peripancreatic, periportal, pancreatic masses, submucosal masses in the small bowel as well as the stomach, adrenal masses, masses around the kidney, collections around the kidney. Even like last week, we had a patient that had 6 months of abdominal pain and 2 months of evening rise of temperature. And everything was normal except that there were 2 lymph nodes surrounding one of the arteries at the greater curvature of the stomach. These were small nodes. They were only 1.2 centimeter in size. But when we sampled them, the diagnosis came as tuberculosis, in spite of everything, including the manto being negative. So there are lots of areas that you can actually reach with the EUS. You can even do rectal EUS and pelvic masses, pelvic nodes, pelvic collections. This is another whole area which has developed a little later and is still being developed, but that's another avenue that we can look at with endoscopic ultrasound. So here's an example. Here you can see this is the pancreas with the pancreatic duct being a little prominent and dilated. Here's the liver, and this is a whole lymph node group that is seen inside the ligaments around the liver. Here's another, this is the liver up here, up top, and you can see a periportal, well-defined shorty lymph node. This is another patient that came with abdominal pain, and this is not a fever under evaluation patient, but it's just to show some examples of EUS-FNA. Here's the pancreas, which looks normal. Suddenly there's a small discrete mass, and then the pancreatic duct proximal to the mass is huge and dilated, and that turned out to be a neuroendocrine tumor, insulinoma actually. This was a patient that had come with fever under evaluation, also had constitutional symptoms of weight loss and loss of appetite, but no, the only thing that was seen was this 8 millimeter mass in the liver, which initially was thought to be a dysplastic nodule, and an FNA was done, and that showed adeno-CA, and IHC showed that it was of pancreatic origin, even though we could never find any pancreatic primary. So there are so many different types of scenarios where the EUS can potentially help us find a diagnosis. So I just wanted to put up this slide because initially, you know, like any of your hypodermic needles, the FNA needle also was just a very simple needle. And because of that, it could only really help in aspiration, and we had to apply suction to the other end of the needle, and you'd get a lot of blood and the sample would be very diluted. And the yield, tissue yield from EUS-FNA used to be around 20 to 30%. And the infections, that became even harder to diagnose. But with time, there have been all kinds of modifications and updations of the needle. They have beveled, reverse bevel, forward bevel, claw-shaped needles, otherwise known as Francine needles. They have bevels on the outside as well as the inside of them. There are fork-tip needles, and all these needles have essentially helped in agitating the tissue around the area, grabbing it into the needle, increasing. So these beveled needles actually give you proper cores of tissue, which have actually made fine needle biopsy much more of a reality and much more of a practicality than actual fine needle aspiration. So coming to what happened to our patient, the 20-year-old boy that had come with fever. So we still continued to look for all other etiologies of lymphadenopathy. Cultures were done, PET scan was done, all kinds of things were done, and finally no other cause was identified. And without any other specific treatment plan in mind, we started him on a short course of steroids. Your usual, 40, 30, 20, 10 tapering dose of prednisone. And his fever subsided within 2 to 3 weeks. And we did a repeat CT after 2 months, which essentially that node was still present, but it was just a normal sized, less than 1 centimeter in size node. And he has been asymptomatic. It's been 4 years now, and he still does not have any symptoms. So who knows what really or why that actually happened, but that was just one of the multiple interesting cases we've had. So essentially the points that we need to take home from this is that areas of the body which were initially considered hidden from the biopsy needle are no longer necessarily hidden with the onset of EUS and EBUS. Tissue acquisition has significantly improved over the past 10 years, not only because of improved EUS technology, but also because of significant improvements in the needles. And EUS screening of the liver and pancreas can often give you information that the CT or MR may not be able to give you. So in cases where you're really stuck and there's no other cause that can be identified, it can be one extra value add-on that might be able to aid in the diagnosis of patients with pyrexia of unknown origin. So with that, I come to the end of the presentation. Thank you all for your patient listening.
We had a question about what are the common complications we encounter in EUS? Are there any serious complications when we do EUS, or is it generally a safe procedure?
It's safe in general, but I think the most important complication is a hemorrhage. You can, if you pass the needle through vessels without properly using the Doppler part of the ultrasound procedure, then you can potentially have bleeding. There are certain other complications related to the scope. You can accidentally perforate the lumen. It has a very long, rigid end of the scope. The ultrasound part is not flexible, unlike the rest of the scope. These are all rare complications. Also, like when you biopsy tumors, there can be theoretical seeding of the tract. So especially when we biopsy tumors of the pancreas, you try to always biopsy through a part of the bowel that will anyway be removed during surgery. So some complications, the most important one is bleeding, but it is relatively safe in general. Yeah.
Okay, and what are the common diagnoses you come across, usually when you go for this EUS and FUO? What are the varied diagnoses you come across?
I think it's in India, we mainly see tuberculosis. The weirdest manifestations of tuberculosis, obscure single node tuberculosis. But then we've had histoplasma, we've had abdominal nodes showing aspergillosis. Then we've had, like I mentioned, one of the case, inflammatory pseudotumors. We have a lot of these neuroendocrine tumors that actually present as fever with some big bowel symptoms. And then sarcoidosis is another one that we have seen in the past quite a bit. Yeah.
There was one question.
Brucella also we have had a few cases.
Okay. There was one more question. Some physicians have a doubt. Is this actually, can we do biopsy through the EUS, or is it only FNAC that can be done? That's a doubt in many people's
So
mind.
there's two types of needles. You can do FNA, which is use an FNA needle, which is a fine needle aspiration. So that's for pure cytology. Then you have an FNB needle, which is a fine needle biopsy. That I had shown some different needles. So there are needles that have these beveled tips where you can actually get a core of tissue. The same kind of core biopsy needles that you use for liver biopsies. It's pretty much the same. So you can get biopsy cores, but forceps biopsy you cannot use with the EUS needle. It's obviously, because it's a needle, you're only using, you can only get what you can get from a needle core. That's it.
Okay. Anyway, thank you very much, Priya, for joining us in this session.
Thank you
I
so
think
much.
this endoscopic ultrasound is a very important modality, especially some patients of ours with FUO, even they're not willing for empirical ATT and all. So
Yes.
the tissue diagnosis helps us a lot, in convincing the patients that actually ATT is required, that it is TB, especially when there are only mediastinal nodes and those sorts of things.
Yes.
So thank you very much. Thank you.
Yes.
We'll
Thank you so much.
moving on to
Thank you.
moving on to the next session.